I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. We're going to continue our series on pediatrics. We've talked a little bit about different things in pediatrics over the last few weeks, and I'm really honored to have this wonderful guest here, Dr. Ishita Kharode. She's the Chief of Pediatric Endocrinology at Richmond University Medical Center. And we're going to look at, in the endocrine world or the hormone world, one of the big things that pediatricians look at and as parents and people who are watching us is whether the height and the growth of your child is normal. And we're going to talk about this more from a physical point of view with regard to height, with regard to development, and see really what do you do when you're concerned about the height of your child. Some people have later growth spurts, things that we'll go really very much in depth into, what treatments are available for the child, and when do we have to be concerned. And that's sort of been the concept of this pediatric series. When should mom and dad get worried? There are times when we know we should be worried. There are times we're not sure we should be worried. And it's so crucial that we use our medical help, your primary care physician, your pediatrician, to really help us. You know, going to the pediatrician's office is not just to see them for 2 seconds or have a stick down put down your throat, but it's really to assess some of the things that you're concerned about. So thank you so much for being with us here today.
Of course. And
we're going to talk about what pediatrics is. So, pediatrics in my day, it changes. It's funny, it could be up to 18 years old, it could be up to 21 years old. A recent pediatrician told me that she sees patients up to 23 years old. So the numbers will go changing a little bit. So tell me a little bit about your training in becoming a pediatrician.
Right. So I first started with medical school. I went to St. George's University in Grenada in the West Indies. Then I did my pediatric residency training at SUNY Upstate Medical Center in Syracuse, New York. And then I specialized in pediatric endocrinology at New York Presbyterian Weill Cornell, which is in Manhattan. And then after graduation, I started working at Richmond University Medical Center, which I am at currently. So.
And we're lucky to have you there. So talk to me. You actually, we discussed before, and you said to me, I'd like to talk about normal growth. And I asked in a simple way, I mean, you want mental growth, physical growth. You said, I see patients on a constant basis who parents are worried about their physical growth. So tell me, when would mom and dad bring a child to you? And does that have to be from a referral from a pediatrician, a general pediatrician? Or could someone just come to call up your office and be seen because they're concerned? And after watching the show, realize that if their child is short stature, that they would go right to the pediatric endocrinologist?
So for the most part, it is through a referral with their general pediatrician. And a general pediatrician, part of their job is to monitor the child's growth and weight gain. So usually if there are any problems or any concerns, the general pediatrician will pick up on something. Or sometimes the parent will go to them if there's a concern in between their checkups. So most often it's a problem that is recognized by the pediatrician, and they'll refer someone to me. On rare cases, sometimes it's the parents who are come directly, schedule an appointment.
So those are the curves that they map out, like how at certain age or a certain height, certain weight, and if you're on, and what concerns us. Again, there's all kinds of standard deviation in statistics. Not everybody is right in the middle at 50%. So what makes us concerned when you look at those graphs? And I think all parents look at those graphs. It's almost like taking tests as a kid. So tell us, what concerns the pediatrician? What concerns the parent?
Yeah, so a lot of times the reasons that someone will come to me with a growth concern is if the child is growing on the smaller end of the growth curve. So as you said, there are percentiles. So if they're growing at the 5th or below the 5th percentile, sometimes that's a cause for concern. Sometimes if either the parent or the pediatrician notices that the child has not grown over the past year or however long it's been since their last appointment, or is not growing enough. And sometimes it's more of a social concern. The parents notice that their child is not as tall as maybe their peers or some of their classmates, or maybe the classmates are growing faster than their child is, and that can cause concern. So it's a variety of reasons.
So let's go with the medical aspect of this process. So if your child is in the 5th percentile or lower, so that's 95% above, what are the more common causes of short stature?
Right. So first, I just want to kind of define short stature. So the current definition is actually below the third percentile for growth. And short stature is one aspect of growth that we get concerned about. The other is what we call growth deceleration. So the child may be at the 20th or the 30th percentile for growth, but their rate of growth is suboptimal for their age or their stage of development. So those are the two aspects that we get concerned about.
What could be some of the causes?
So some of the causes are may have to do with nutrition. So if the child is not gaining weight appropriately, either because they are not eating enough or if there is something else affecting their nutritional status, like a gastrointestinal problem.
Are you seeing that more? I mean, there are issues of the economy. You know, we have a large population of patients who've come from foreign countries recently, who I'm seeing in my clinics. I'm sure you're seeing in your clinic also. Are you seeing some issues like this because of people coming in who might not be getting the nutrition that they need?
Sometimes, not as much. I think maybe the gastroenterologists are probably seeing more of that than I am. But I do occasionally see someone who is not, getting adequate food intake. But a lot of times it may be something more intrinsic going on in their gastrointestinal system. And sometimes it can have to do with hormones. If we're not making enough of particular hormones, such as growth hormone or thyroid hormone, that can certainly affect growth. Sometimes it may be something more mundane, such as that the child is growing appropriately. It's just that they may not be at the stage of, have undergone their growth spurt yet. So they're growing appropriately for where they are, and they'll catch up, eventually.
I remember being in medical school a little while ago, and there was a pediatrician who really was a mentor of mine. I thought he was marvelous. He was so kind, and I think that's always the beautiful thing about pediatrics. Everybody's so kind in the field, usually, overwhelmingly. And there was a child who came in who was short stature. I don't know if it was the third percentile or not. And the first thing, and he asked me, what do you think could be the cause of this? And I said, where do you start? And we're going to ask you where you start. But he pointed to me, he said, look over there. And what did I look at? I looked at the parents. So if the parents were short, he said, you can't expect the child to be much taller, or at least for whatever reason. So tell me a little bit, where do we start?
So the first thing we have to determine, is there actually a problem? Is there a concern to be worried about? So I look at what is the child's height and what has the child's height been over the past few years. So usually before puberty, a child should be growing, whether it's a boy or a girl, should be growing at a rate of about 2 to 2.5 inches per year. So is the child growing at that rate, or is it lower than that? Other things I look at are, as you alluded to, the parents' heights. There's a formula that we use to calculate what's called the mid-parental target height, which gives us a very, very rough idea of how the child should be growing compared to their parents and their family, their genetics. It's not a perfect measure. As I said, it's a very rough estimate, but it gives us some idea. So if that number is, for example, at the 70th percentile and the child is growing at the 10th, then, that's a little bit of a discrepancy. So that might be cause for concern. So I look at those things. It also, I look at where they are in their puberty. Have they started to develop yet? Because that lets me know how fast they should be growing as well, because the growth speeds up during that time. So if I look at all of those things and either they are not growing at the correct rate, or if they are growing at a rate far below their mid-parental target height, then that's where we start, is by establishing whether or not there is a concern.
And is there any blood tests? You mentioned growth hormone, thyroid hormones. So, and then nothing is standard in medicine, obviously. But is there a part of a workup that you do? Do you do X-rays to see whether there's fusion of the bones, or the growth plates that are there? What kind of a workup? When a parent comes to you, and this is, I always want our audience to get an idea. When you go to the doctor's office, what are they probably going to ask? What are they probably going to do? If I walk in there with a child who might be shorter than what I thought would be appropriate or normal for their age, what are they going to do? Are they going to do x-rays or send me for x-rays? Are they going to get blood work? Is it just going to be an exam? Not just, but it's going to be an examination. So tell us what parents, mom and dad, would expect to see when they come into you.
Sure. So after I've looked at all of those things that I mentioned, if I see that there is a cause to be concerned about the child's growth, then we do typically start with a lab evaluation. So we check multiple things. It's a very broad screening evaluation. So I check for any signs of anemia, liver, kidney dysfunction, any signs of inflammation, thyroid hormone levels. I check for signs of celiac disease. So this is a typical starting point, and depending on what I find when I examine the child, I might add on extra tests.
So celiac disease is different than gluten intolerance.
They're related.
Right.
It's celiac disease is an autoimmune condition that leads to that is exacerbated by gluten intake.
Right. And children with celiac disease actually who've had the diagnosis made, and that's a more complicated diagnosis than a gluten intolerance process. In those kids, they could be short-staffed. They could have a problem with growth.
They could, and it's mainly because they're not getting enough nutrition. It affects the nutrients being absorbed into their intestines, and so most of the time they also have poor weight gain or slow weight gain or weight loss, and then in turn that leads to poor growth.
So we talked about the blood work. How about x-rays?
So I do often do an x-ray of the hand. It's called a bone age x-ray, and that allows me to look at the child's bones and their growth plates because those appear differently at different ages. And so compared to their actual, what we call chronological age and their bone age, the two of those, between those, I can see how much room there is left for the child to grow, how close is this child to being done growing. It gives me an additional information about what to expect.
So now using that information, how do you decide when and what to treat with, when not to treat? And because sometimes mom and dad come in and they're sort of, sometimes they're expecting things. They're expecting, people have expectations. I think that I'm going to go on some medicine or my child's going to go on some medication. I think sometimes it's hard for them to accept that there's really nothing that we do or we should do. So what discussion do you have, again, both ways, if there's something that's concerning or something that's not concerning? What do you tell them?
So the first thing is in that initial blood test list that I mentioned earlier, if anything comes back abnormal, then of course we have to start there. So if there is, something indicating that the child's thyroid is not working well, or something that suggests that they may have an inflammatory bowel disease or celiac disease or something like that, then we would act appropriately depending on whatever the situation is. Sometimes they may need a referral to gastroenterology if they have an intestinal issue or something that suggests an intestinal issue, so that'll, they'll carry on the workup from there. But if everything comes back normal, and then I, of course, look at the x-ray and see how much room there is to grow, we may do one of two things. We may monitor the child, and sometimes it's a very individualized decision, so it's a very case-by-case basis. But if it's determined that the child is medically healthy, the lab tests are normal, the child has plenty of time and room to grow, and we can kind of see how their growth, maybe it picks up over the next few months, I may bring them back in 4 to 6 months to kind of see if their growth rate improves. If I'm very concerned that the child is closer to being done growing than I'm comfortable with, or if the child is really not growing at a rate that is healthy, then I may do further testing specifically for growth hormone deficiency.
So when would you use growth hormone in children? I mean, growth hormone has been touted, and again, I know you're more on the pediatric side, but clearly your education and knowledge is wonderful with regards to this. So educate us all. Growth hormone, and again, not to be funny, is being used in adults for keeping people youthful, rejuvenating their life, all kinds of other things. In the pediatric world, clearly we're looking for this to be a growth hormone to help you grow. When would you use growth hormone, and when should parents think that a pediatric endocrinologist, or I don't know even if a pediatrician could prescribe growth hormone, when would they consider doing that?
So first we have to test for growth hormone deficiency. That's the primary reason to use growth hormone if a child is not making a sufficient amount. And that's a little bit more complicated than is sometimes realized. Growth hormone is produced in our bodies usually at night. And so it's not a simple blood test that we can do during the day to measure a growth hormone level and say it's low, because it usually is in most people. So there's a more involved test that we do. And here at Rumsey, we do it in our hospital. There are some places that do it outpatient, but it's a more complicated kind of 3-hour-long test that we use to test if the child is making sufficient amounts of growth hormone. If they're not, then they're considered to be growth hormone deficient, and that's a situation where growth hormone would be helpful.
Is there any other times you use growth hormone?
There are other approved indications for growth hormone therapy that don't require. Usually these are syndromes such as Turner syndrome, is one of them. There are certain gene mutations, gene deficiencies, which are kind of more rare conditions. There are conditions, again, this is a very individualized case-by-case basis, but where you may consider trialing growth hormone, even if the child is making a sufficient amount, if you are really worried that the child is not going to kind of grow as expected, if you're really worried about the child's growth rate.
I'm going to jump a little bit in the same topic. Politically correct terms. I mean, we use them. I had a guest on that we were talking about with regard to autism spectrum and cognitive issues recently. Tell me correct terms for people of short stature. I mean, there's medical terms of dwarfism. There's all kinds of things. So what kind of terms would you use? And again, both the medical and even in the vernacular for the population. What do you tell people?
I mean, I for myself, I think I would use the terminology just based on what they have. So if the person has achondroplasia, that's a medical diagnosis that can lead to very short stature. So I would just refer to the condition that they have and also go by what that individual person would like to be referred to as. I think I've heard the term little person more frequently recently. So I know that is a term that a lot of people prefer who are of extremely short stature. But I think for the most part, I would just ask the person how they would like to be referred to, because I don't think there's any general consensus on that.
In our medical field of today, and not to talk about whether it's right, wrong, or judgment, if somebody is born and you know that they're going to be a little person of very extreme short stature, are there treatments there other than growth hormones? Is there enough medical technology available today that someone who was born from parents who were little people, whatever word, achondroplasia, whatever word we use, with different diagnosis, could most of those patients achieve normal size, or is just some things that really we just can't do anything about?
I think it very much depends on what the exact diagnosis is. So something like achondroplasia is really more of a skeletal dysplasia, so the growth is just disproportionate. So in those situations, typically we don't use growth hormone because the growth would be disproportionate in terms of the limbs and the spine and things like that. There are other newer medications for achondroplasia that have come out. But to my knowledge, these are not medications that necessarily achieve sort of a normal or average height, as we would call them. So that those are sort of more specific medical conditions. In cases where the parents are of just, average short stature, they're shorter than the average population, but they don't necessarily have a medical diagnosis. In those cases, the child may be, through the workup that I mentioned, be diagnosed with a condition that may be treatable. But it really just depends on what's going on with the individual patient.
So let's give almost the exact opposite. When you see two people who have short stature, and they have a child who has above average height, what happened?
There are situations where the parents themselves may have had an undiagnosed medical condition, or maybe they grew up in a situation where they didn't receive adequate nutrition and that affected their height and weight. And so they reached a height that was maybe not what they were supposed to achieve based on their own mid-parental target height, genetic potential, whatever you want to call it. But the child grew up in different circumstances. Maybe the child had adequate nutrition that allowed them to grow and develop in the way that they were supposed to. So that is a situation that we do see very commonly. And it doesn't necessarily have anything to do with any intrinsic medical condition so much as just the circumstances in which, the parents and the child grew up.
How about also general well-being type things? Does cigarette smoking amongst parents lead to short stature? Does alcohol overuse around the time of pregnancy lead to short statures? Are any of those things that are related?
I mean, they can be sometimes. I think, again, it really depends on the situation. But like fetal alcohol syndrome can sometimes cause short stature in the child. Cigarette smoking can these conditions more lead to what we call intrauterine growth restriction. So the child may be small when they're born. But then after that, once the effects, of what happened during the pregnancy wear off, sometimes, they're not long lasting. In the case of fetal alcohol syndrome, of course, it's a little bit different. It also depends on when the exposure occurred, all of those things. So a lot of times, any toxic exposures more affect the child at the time of birth, but there are some that can cause long-lasting effects.
And the growth hormone issues that we were saying both were with men and women. Is there a difference between the two when you talk to a mom and dad and the child who comes in? Is there any difference in your thoughts if it was a boy or a girl?
So the main differences are, the growth charts are different for boys and girls. So that affects the percentile. So a boy and a girl of the same age may be at a different percentile for their growth. Also, the ages in which they start puberty are different. So those discussions depend on the child being a boy or a girl. And then also, just the formula that we use to calculate the midparental target height is also different for boys versus girls. So those are the main differences. Other than that, I think that it's more of a societal, difference in which girls are. It's more socially acceptable for girls and women to be on the smaller side than boys and men. It's not necessarily something that I personally use to dictate whether or not to start treatment for someone. It's more just sometimes the expectations that families have for their children on whether they're a boy or a girl and kind of expecting them to reach a certain height.
Tell me about puberty. So when boys or girls reach puberty, growth might accelerate for a short period of time, but then the growth plates, that's towards the end. So tell us, what do families expect that after puberty?
Right, so it's very important to know whether a child has started puberty or not and where they are in that process, because the growth rate is very different. So as you said, the growth rate does speed up during puberty. And specifically the growth spurt, as we call it, which is sort of the peak growth rate that we see during that time, occurs at a different stage for boys and girls. So boys not only go into puberty later than girls on average, but their growth spurt also happens during the later stages of puberty. Whereas for girls, it happens earlier, and the growth spurt happens towards the earlier stages of puberty. The whole process typically lasts for about 2.5 to 3 years. And then at the end of that process, after the growth spurt, the growth then typically slows down. So a lot of times I will every now and then have patients come in because the pediatrician or the families are concerned that the child hasn't grown in the past 1 or 2 years. But then when you kind of track their growth over the previous few years, you can see that actually the child has already finished growing. They underwent a growth spurt. They're approaching their final adult height.
You can almost tell that by the X-ray, I think.
You can tell that by the X-ray. So the closer you are to being done growing, the smaller the spaces in between the bones get. But also you can tell them that by doing an exam, to assess where the child is in puberty, which is typically done at the pediatrician's office or in my office if they're referred to me.
So tell me about something that everyone is concerned about. And I've seen this so many times where people come to me. The concept of growing pains. So we see someone who's growing quickly. Boys sometimes more than girls. I'm not sure why, probably because the growth spurt might be a little bit more robust. Things hurt. And I have patients coming in, again, I see some teenagers, and everything hurts them, at least, or one leg hurts them. And we do so many tests, and we look at the leg, and we try to figure it out. And sometimes families skip the pediatrician and just come right to a neurologist. This might be a little bit of swelling, a little bit of numbness, something that brings them to my office. And I look and I just can't find a darn thing. And I look and then the person goes to the pediatrician. A lot of teenagers skip some of those pediatric visits. And the pediatrician said, "What are you guys talking about? You just have growing pains." So maybe tell everybody what growing pains are. Is there any science behind it, or what are those pains these kids are having?
I think probably the best that I would say is that as you grow, sometimes as you go through the growth spurt, the growth rate increases, and that can sometimes cause discomfort. There's no specific test or anything that we can do to see whether this is growing pains or not. I think the main thing to just realize is that, there can be certain signs and symptoms that would cause more concern, that this is not just growing pains. If you have, a particular swelling, or if you're not able to walk, if there's a limp, something like that would cause more concern. If everything is otherwise okay, then it most likely probably is some form of growing pains. It's not really a medical term, but, we sort
of attribute. Is
there
a medical term for it?
Not that I use, no.
It just hurts.
It's just some, a minimal discomfort that you typically get, or sometimes just the activity, daily living, the activities of daily living, whether it's sports or just walking throughout their normal day. There are other things that can cause that sort of pain and discomfort that may not immediately come to mind for them.
So 90% of our program has been to short stature. It would be unfair, and I think, not to talk about people who might come in who are too tall. And we think about wrestlers, famous people, whether it was presidents like Lincoln. And there's all these concepts about who is too tall and who is abnormally tall. And we think about our sports legends and sports heroes. So tell us, what happens if someone comes in and they're worried that their child is just growing too quickly?
So again, you have to look at what is the growth rate. Also, the parents. A lot of times when a child is tall, the parents tend to be tall. And so you have to kind of see how the child is growing in comparison to that. Sometimes as well, the child may be growing too quickly compared to their peers because they're developing earlier and they're undergoing their growth spurt at an earlier age than their peers are. And that age may be a normal age. It's just that they're kind of an early bloomer rather than a normal or a late bloomer. So compared to their friends, it seems like they're taller, and then maybe over the next few years, things will kind of balance out as everybody else goes through the same process. Of course, there's other, genetic syndromes and things like that you want to also check for, and there's, various signs and symptoms associated with different ones. If there's any other abnormal physical exam findings, or if there's any other things in their medical history that kind of make you think maybe there's something deeper going on. But a lot of times in terms of tall stature, it tends to be either familial, that it's appropriate for the family, or that they're developing, earlier than expected. Just
in the last few seconds that we have, talk about the psychosocial issue. I know I'm more of a structural neurologist, and you're a pediatric endocrinologist, but all pediatricians, all physicians have to really deal with the whole family. The idea about kids who are too short, kids who are too tall, who stick out, do you try to counsel the families about normalcy and that things will eventually work its way out?
I mean, if the child is medically healthy, which is to say that their lab evaluation is normal, they're growing appropriately for their family, they don't have any concerning signs or symptoms, and they're projected to reach an appropriate height for their targeted potential, as the familial potential, then yes, I do, counsel them in the sense that, sometimes what we think of, what we expect as a normal height, or the height that they wanted to be, may not necessarily be the height that they were going to be in terms of from a medical standpoint. And if they're otherwise healthy, then really that's the most important thing, is to make sure that the child is medically well. Sometimes there can be a stigma, sometimes, and a lot of times it has to do with their own expectations of, I wanted to be 6 feet tall, or I wanted to reach this particular height. But, of course, all of our problems are not solved by reaching a particular height. As long as you're otherwise okay, that's really the main thing, is to have a healthy child.
That's, of course, to all of us. We should all have happy and healthy children, and we'll be happy and healthy ourselves. I want to thank you so much for being here tonight. And I want to thank everyone for watching us, and hopefully we learned a little bit about being too tall, being too short, and hopefully all being in the same world and doing well with each other. Have a wonderful evening, everyone.